Our next lecture is Focus in the Trauma. That means point of care ultrasound in the trauma. Ultrasound is relatively inexpensive, rapid, non-invasive diagnostic tool. It is not associated with any radiation hazards. ASA has also recommended POCUS certifications with 3 primary and 3 secondary applications. Dr. Eric would be joining us online from USA to expound the use of POCUS in trauma. I would like to call Dr. Ashok Deshpande sir on stage to chair this session. Deshpande sir is a very senior anesthetist and he is working since last more than 40 years. At present, he is HOD at Skill Lab BVDU MIRAJ-SANGLI. He is National Governing Council member ISA since 2019. I would also like to call upon stage Dr. Ulhas Misar sir to co-chair this session. He is professor and head of the department at Anesthesia Department of Government Medical College, Miraj. He is teaching since last 23 years. I request Dr. Ashok Deshpande sir to briefly introduce our eminent speaker, Dr. Eric.
Good morning, everybody. Dr. Eric Heinz, he is an associate professor of anesthesiology and critical care medicine at George Washington University, USA. He is my friend, and we had a lot of academic discussions on the net so many times. He works in critical care medicine also, and he has got a role in the clinical and research experience. He was working in COVID also. So his main interest was to give protection or the safety of the patients. He works in pain management, but his main interest is post-operative pain. He works in the field of development of anesthesiology also. And he has got certain specifications. His main interest is trauma anesthesiology, airway management, perioperative care, and point-of-care ultrasonography. He published papers on POCUS and airway management. He is an associate editor of Journal of Perioperative Medicine, Canadian Medical Education Journal, and his main interest is POCUS. So I asked him to please deliver a lecture on the POCUS today. So I request Aries to please start his lecture. Please focus the Aries. Aries, please.
Hello, can you hear me?
Yeah. And
okay,
let me tell you all of you that it is 12:30 in the night at his place. But I requested him, please be aware of all these things. Okay, Aries, you can start, please.
Okay. Good evening, good morning, I guess, to you guys. But yes, it's definitely dark here. So I'm Eric Heinz, and the title of my talk is Point of Care Ultrasonography or POCUS for the Trauma Patient. Before I begin, I would like to state that I have no disclosures, either personal or financial, to make regarding this talk. So George Washington University is located in the heart of Washington, D.C. on the west end, and we our level 1 trauma center. This was our trauma activations for 2022. The green line is the trauma yellows, which are the more severe mechanisms of injury. And the purple line is the trauma whites, to which the anesthesiologists typically do not respond. There were about over 2,000 cases last year, and you can see they kind of peak in the summer months when it's warmer and kind of tail off in the winter months when it's colder here. The majority of this talk will be based on 2 recent review papers that me and some colleagues wrote. And if there's any questions, it's a lot of material, I understand, and a short amount of time. So if you would like more information, feel free to reference these articles. And if you have any difficulty accessing them, please feel free to email me and I can share them with you. So the objectives of today's lecture are explain how common point-of-care ultrasound techniques can be used specifically for trauma patients. And in doing this discussion, what I will try to do, hopefully clearly, is differentiate between point of care ultrasound for your elective patients that come in for pre-surgical testing or an operation versus the trauma patient where the setting is much more acute and time is sensitive. And so I'll try to differentiate those two. And then secondly, to demonstrate an understanding of the risks and benefits of using POCUS for the care of trauma patients. The outline, I'll talk about the four main categories of point of care ultrasound, that being cardiac, thoracic, gastric, or the fast exam. And then if there's time, I'll discuss ocular and point of care ultrasound in pre-hospital care. So the benefits of point of care ultrasonography is it's quick, it's inexpensive, and it's non-invasive. These all lend themselves to trauma care when time is sensitive. So we'll explore that more as I move on. So for cardiac POCUS, starting there, cardiac POCUS is not meant to be a complete echo exam. It's simply to assess for any areas of cardiac trauma, such as aortic injuries, cardiac tear, or valvular injuries in blunt chest trauma. Now, the cornerstone of cardiac anesthesiology is a transesophageal echocardiogram. And this is one protocol that's used at Toronto, actually, to do a TE protocol on a trauma patient. And it's mainly looking at mid-esophageal. I understand this slide has a lot of information and is probably rather small, but basically you're trying to assess LV and RV function and then to determine if there's any traumatic injuries, such as aortic injuries or injuries to the pericardium. Now, TE, it's important to remember there are certain precautions and contraindications to consider in trauma patients, which include, for example, a spinal cord injury, a coagulopathy, as we learned in the last lecture, and then possible esophageal injury. These are rare, but potentially possible. And then providers should assess the mechanism of injury and determine if any of these are present prior to performing TE. In addition, simple cardiac POCUS can be used to predict survivability to hospital admission in patients presenting in PEA arrest. For example, a subxiphoid view of the heart, if there's any fibrillation on presentation, that's a relatively good sign for patients that are in PEA arrest. If they don't have any fibrillation on that view, their likelihood of being surviving to admission into the hospital is 33 times higher than, or I guess lower, excuse me, than if there's no activity. In addition, we can look at the IVC, the inferior vena cava. As we mentioned in the last lecture, many patients show up already in shock. The estimated blood loss prior to admission to the hospital in the field is unknown. So the volume of the IVC and its compressibility can be assessed using abdominal ultrasound. It's predictive of the transfusion requirements within the first 24 hours of admission, and it's more expeditious than sending the patient to a CT scanner. So in the next slide, we'll look at IVC collapsibility. In the left panel, you'll see over here the IVC running through the middle as a hypoechoic structure surrounded by the liver on both sides, the diaphragm in the cranial direction, and the spine in the inferior portion. And on the right, you'll see a severely collapsed IVC suggesting shock. And anytime the IVC diameter is less than 2.1 centimeters or that it collapses greater than 50% with inspiration is suggestive of IVC collapsibility and volume status in these trauma patients. Now, sometimes the abdomen, there's either traumatic wounds there, as we saw in the previous lecture, some slides of potentially burns to the abdomen or something like that. An alternative site to investigate would be the internal jugular, which may be more accessible at the head to us anesthesiologists if it's intraoperative during an abdominal surgery or something in those lines. Moving on, we're going to talk about thoracic POCUS. And since the late 1980s, thoracic POCUS has been used to study pneumothorax and to assess for pneumothorax in trauma patients. There's 3 signs for a pneumothorax, and we'll go through each one of them with images. One is a lung point. The next one is lung sliding versus lung pulse. And the third one is M mode or motion mode, in which we can assess for signs of pneumothorax. So lung point, first here you can see at the green arrow, an obvious demarcation of normal, healthy lung tissue on the right, and then the disappearance of that tissue on the left, suggesting pneumothorax. Now, some authors have suggested that this is 100% reliable test and it's pathognomonic. There have been some rare case reports of pseudo lung points or physiologic lung points, but again, those are rare. So if you see a lung point on an exam, it's pretty much pathognomonic for pneumothorax. Moving on to the next one, and I'll go through these. On the left image, what you'll see is lung sliding, and this is actually a video, which I can hopefully play. And you'll see in this image, when you place the probe on the lung, you can see the pleura sliding left and right. I'll play that again. You can see it sliding left and right. And that's indicative of the pleura actually moving in the chest wall. And on the right, what you'll see is not the sliding left and right, but more vertical bouncing up and down. And that's reverberations from the heart. So it's termed the lung pulse. And that's indicative of a pneumothorax. Or alternatively, this can also be indicative of a right mainstem intubation if the tube is actually in the right lung, if you place the tube too deeply, the endotracheal tube. So both those are indications that you could have either a right mainstem intubation or a pneumothorax. And then the final one is M mode or motion mode. In the left image over here, you'll see what's called the seashore sign. And this is called this because this has this appearance of a seashore with the waves out here and the sandy beach down here. Now the sea, this portion here represents the skin, the muscle, and the pleural line. And then the shore, this part of the image down here, is artifact of lung motion. Whereas in a pneumothorax, what you will have is obviously no lung motion, and you have this, what's called a barcode sign up here. And that's similar up here where you have the skin, muscle, and pleural line that looks like the sea, but down here you lose the sandy beach and it becomes a barcode appearance, and that's the sign of no lung motion below the pleural line. So the optimal scanning for a pneumothorax is to start peristernal at the just below the clavicle and come down to the liver point or the cardiac point on the other side, and then to scan back up to the midclavicular line just under the shoulder. And this can be done rapidly and in less than 2 minutes and should cover most of the lung zones. So it could be a rapid exam that you can do in less than 2 minutes to find or to assess for a pneumothorax. And then finally, hemothorax is something else you can assess in using thoracic POCUS. It's not as specific, and there's particularly known peristernal that hemothoraces can actually hide or be hidden from by the sternum. So sometimes it's harder if you have an index of suspicion that there's a hemothorax near the sternum, you might need more sophisticated testing. So moving on to airway POCUS, there's three main indications for airway POCUS. One is prediction of difficult airway. The second one is confirmation of ET2 placement. And the third is identification of the cricothyroid membrane for in the event that you need a surgical airway. Now, prediction of difficult airway, typically the Mallampati score is what we use. I have trainees come up to me all the time and report the Mallampati score of a patient, but in fact, it's actually a poor predictor of intubation difficulty. It has a very low sensitivity in the range of 40%. And so over the past 10 or 15 years, different ultrasound parameters or measurements of the upper airway, the laryngeal structures, over 25 of them have been suggested to assess for a difficult airway. And the skin to epiglottis is, these are two recent meta-analysis that were done in the past year on all the studies that have been done on those 25 plus different parameters. And what they found is the skin to epiglottis distance at the thyrohyoid membrane is the most predictive of a difficult airway. It actually has a better sensitivity and specificity than the Mallampati score. So the skin to epiglottis distance is indicated here. So again, a transverse ultrasound probe is placed at the thyrohyoid membrane and just below the surface, what you'll see is the hypoechoic, I sometimes call it a football shape as it appears here. That's the epiglottis. The bright hyperechoic line below it is the air mucus interface. And sometimes you'll have reverberation effects coming down. It's not particularly noticeable in this image, but this would be measured the skin to epiglottis distance, and that is predictive of a difficult airway. Now, this is the only study that has been done in trauma patients specifically, and this was a prospective study done on 60 trauma patients, most of which were motor vehicle accidents, and they measured the soft tissue level of, at the anterior neck at 3 different levels: at the hyoid bone, the thyrohyoid membrane, and at the level of the vocal cords. And the important thing, they didn't find any definitive predictors of difficult intubation, but they said this test can be done in about 60 to 80 seconds, whereas the typical fast exam typically takes about 2 minutes. So it can be done rapidly. They did not look specifically at the skin to epiglottis distance because this was actually, the study was done prior to those previous meta-analyses that I referenced. The next indication for airway POCUS would be to differentiate endotracheal from esophageal intubation. And the great benefit of this exam is it can be done real time. So the way we typically assess for endotracheal intubation, especially in the trauma bay, is we listen to the lungs, we auscultate once the tube is placed. Now, in our trauma bay, it can be extremely loud and chaotic and sometimes difficult to hear. The other indication that we use is colorimetric change. But if the patient has no cardiac output, it would be difficult to see colorimetric change secondary to the carbon dioxide. So this test is extremely useful as it can be done quickly and it's done in real time. And so the image here up top shows the patient. You use a linear probe and it's placed right above the sternal notch. And what you'll see on the bottom is actually with an endotracheal tube in place. And this is called the bullet sign. As you see the blue outline represents the shape of a bullet. Over here, with the white arrow, what you see is the constricted esophagus. So this is a good sign. The bullet sign indicates that you are endotracheal, whereas if you place the endotracheal tube actually erroneously into the esophagus, you'll have this image over here on the right, where you have esophageal intubation. And this is termed the double track sign. That being because on the left here, you can see the intact trachea. And most importantly, what you see is the posterior aspect of the trachea, which is not present over here in the bullet sign. That's been covered up by the endotracheal tube. But over here, when your endotracheal tube is actually in the esophagus, you will see the posterior aspect of the trachea present, and you will see a dilated esophagus with the endotracheal tube in. And I think this will become more clear in the next slide. But again, on the left, endotracheal is bullet slide. On the right is esophageal with a double track sign. So in this next slide, I have a video that's representative of this actually being done in real time. And I will try to narrate it. It's rather short, but I'll play it once or twice so that we can see exactly what's going on. So in this case, you can see the esophagus is over here and the tube is there. Now the provider realizes that. In addition, you can see over here the posterior aspect of the trachea. Now the provider has, at this point, pulled out the tube. You have the constricted esophagus, and then the provider will then place the tube into the trachea. Again, here you can see the posterior aspect of the trachea, so you realize that the tube is not there. And I'll continue the video. So at this point, the provider has realized that the tube was in the esophagus and is now placing it into the trachea, and you see the disappearance of the posterior aspect of that trachea, giving the bullet sign. I'll play it once more since it's so short. So esophageal, double track sign. Provider realizes it, removes the tube, the esophagus is constricted, and then place the tube in the trachea, and the posterior aspect of the trachea disappears. I hope that was clear. I know it's a short video. The next indication for airway POCUS is for cricothyroid membrane localization in the event that you need or are anticipating a potential surgical airway. So there's two methods for doing that. One is holding the linear probe in a transverse direction on the anterior neck, and that's called the TACA method. The next method is sagittal scanning, and we'll look at images of both those. So we'll go first to the transverse scanning. Again, this is called the TACA method, where the linear probe is placed on the anterior neck at the level of the thyroid cartilage. And you scan in a caudal direction, and then you scan back up in the cephalad direction, in order to determine the level of the cricothyroid membrane. So we'll go through it step by step. The first is the thyroid cartilage, which is seen here with these bright arrows, and you have a hyperechoic kind of triangular structure, which is represented by this red triangle. Then you scan caudally, and you come to the cricothyroid membrane, which is present here and is evident by this hyperechoic line, which again is the air-mucus interface. And that is the A, or the airway. And then you continually scan in a caudal direction, and you come to the cricothyroid membrane, which is this horseshoe-like structure here in red. And then you scan again in a cephalad direction, so you come back to the airway, and you can confirm that you have the actual cricothyroid membrane. Plenty of studies have been done on this method. It's not important where the position of the head, whether the head of the bed is elevated or supine. It's just important that if you're going to do the surgical airway and you've identified the cricothyroid membrane, that the head is in the exact same position, because the cricothyroid membrane will move based on the elevation of the head of the bone. So the next method is the sagittal scanning. And here you'll see on the left this linear probe placed in a sagittal direction on the anterior aspect of the neck. And this is what you see, a representative image. This hypoechoic area that's colored in blue is the thyroid cartilage. Then you have the cricothyroid membrane, which is represented by this air-mucus interface, this hyperechoic line. Then over here, you have the circumferential cricothyroid membrane. And if you continue scanning in a caudal direction, over here, you should see the green, the first ring of the trachea. So this is another method to identify the cricothyroid membrane. Now, these methods have been shown to be particularly helpful in a patient with a normal small neck. You should be able to palpate the cricothyroid membrane, but these have been shown to be useful in patients with large necks, with neck pathology, such as goiter, or in patients who are pregnant. So this is a method that can be used to identify the cricothyroid membrane in the event that you might need a surgical error. Interestingly, a study was done, a feasibility study that was done on 40 volunteers, patients that were not trauma patients, but they were placed in a cervical stabilization collar to simulate a trauma. And in 100% of the patients, they could find the cricothyroid membrane using ultrasound just through the window of the cervical stabilization collar. Again, this is a simulated situation. It's not actual trauma patients, but the feasibility is that it can be done in a patient with a cervical stabilization collar. And we have actually done at George Washington studies of using similar studies, but trying to determine endotracheal versus esophageal intubation that we saw a few slides ago. And over here, you can clearly see the bullet sign. And here, this is just us scanning a patient that's obviously intubated through that little window in the cervical stabilization column. In addition, there have been several case reports of using airway POCUS to assess for trauma pathology to the neck, such as paratracheal hematomas or airway injuries, but there's been no retrospective or even prospective controlled studies, just simply case reports. And based on the level of index of suspicion and the status of the patient, their level of respiratory distress, you can decide as a provider if there's time to perform a airway exam using ultrasound, or if you just need to move ahead and manage the airway. Now moving on to the next topic, which is abdominal POCUS. The indications for abdominal POCUS are FAST, the extended FAST, and then NPO status. Moving on to FAST, here in the States, what the FAST exam is typically done by the trauma surgeons, but I think it's important for anesthesiologists to be aware of it, not just because we are a member of the care team, but also it can be used perioperatively in any critically ill patient to assess for intraperitoneal fluid. So the first two categories of the EFAST exam are thoracic and cardiac, which we already spoke about. And then the abdominal portion is the right upper quadrant or the perihepatic space or Morrison's pouch, where fluid can collect. The left upper quadrant, the splenorenal area, where fluid can also accumulate, and then the suprapubic area. Now, right upper quadrant and left upper quadrant imaging has a very low sensitivity, but high specificity for detecting fluid. In addition to its limited sensitivity, it takes approximately 500 cc's of fluid to become detectable in these views. So not the best sensitivity there. For the NPO status, gastric ultrasound has been done looking at the antrum of the stomach, which is the most dependent portion of the stomach. So if there's any contents in the stomach, then it can be assessed by using abdominal ultrasound. In this exam, we actually use a curvilinear probe, and this is typically done with the patient both supine and in the right lateral cubitus to increase gravity to push any fluid or abdominal contents towards the antrum of the stomach. Now, the reason the antrum is a target is because it dilates in a linear fashion with the amount of contents that are present. Now, you can imagine in a trauma patient that has abdominal injuries or is in distress, this may not be easy to put them in the right lateral cubitus. And typically, quite honestly, the NPO status is always assumed to be full stomach in a trauma patient. So these are some representative images of what you might see on a gastric exam. On the left is basically an empty gastric antrum. Here you see the bullseye or target sign, which is a completely collapsed gastric antrum. This patient has been NPO for definitely more than 8 hours, and there's very little to no contents present in the patient's gastric antrum. Just to orient us, this is the liver here. This is the gastric antrum. Occasionally, you can see the pancreas just below the gastric antrum, and then the IVC here. In the middle image is somebody who has recently drank fluid. Again, you can always find your liver. It's rather easy to find. Your great vessels down here. And in this case, the gastric antrum has more fluid in it, and it actually has a speckled appearance, which is sometimes referred to as starry night appearance. And that's indicative of somebody having just ingested some water recently and these air bubbles being present. And kind of the extreme of images over here is a patient who has a full stomach, who recently ate solid food. The liver is here, identified, and you see the gastric antrum, but it has this kind of distended and frosted glass appearance is the term that's used. Frosted glass appearance represents a full stomach. And this next slide is just an image that shows, again, that the gastric antrum, the surface area can be actually measured, and it's representative up here. The ultrasound will actually measure it for you by encircling the outer aspect of the antrum or the muscular layer, muscularis proprii here. You can actually get an actual surface area and a volume that can be calculated to determine how much is actually in the gastric antrum. And then, since all those images were beautiful and crystal clear and very easy to identify, this was actually a gastric ultrasound that I did on a patient who came in actually with a self-inflicted gunshot wound just under the sternum. And you can clearly see the liver over here, but not much else is identifiable here. And the patient was actually relatively stable. So we actually sent the patient, the FAST was indeterminate. The patient was stable, so the patient was sent to the CT scanner, and then in this process became a little bit unstable, so was taken to the operating room for an exploratory laparotomy. And when the CT came back, it showed that there was damage to the greater curvature of the stomach. There was a large hematoma from a liver wound. There was a splenic vessel rupture, so clearly a lot of intra-abdominal trauma from this gunshot wound, and that can be depicted here by the not so clear or textbook picture of the gastric pocus. Moving on briefly to the transocular sonography, the optic nerve sheath diameter has been used to measure the ICP, as the optic nerve sheath is in continuous connection with the intracranial pressure. A measurement of greater than 5 millimeters has correlated with an ICP of greater than 20 millimeters of mercury or higher. And I just have one image here to show in this exam, what's done is a linear probe is placed just above the orbit, and it's important. So you have the globe here, You have the optic disc here, and then what's important is that you have, as the optic nerve can have a kind of jagged course or not direct course, so you can use color Doppler to ensure that the vasculature is running in a linear direction. And again, the hypoechoic area is actually the optic nerve, and the hyperechoic area just lateral to that is what you would measure, as that's the optic nerve sheath diameter. And in addition, ultrasound has been used in pre-hospital care of patients. This journal showed that basic trauma sonography skills can be taught to paramedics in a relatively short time. Paramedics gained sufficient knowledge in a 6 to 8 hour course and could use these skills to identify pneumothoraces or identify shock that might occur by IVC collapsibility in the pre-hospital care of patients. So POCUS education training has been a big goal of ours at GW. Here we are training some of our trainees intraoperatively with colleagues of mine. Interestingly, a study was done, a survey a year or two ago, and they asked attending anesthesiologists what their comfort level was. And basically, the anesthesiologists felt comfortable using ultrasound on a daily basis to either gain vascular access or do some sort of regional block. However, rarely did physicians know how to assess the heart, the cardiac status, or any respiratory status in the lungs. And so kind of the barriers to education and training and implementation of point-of-care ultrasound is the lack of any programs, educational programs out there, the lack of educated or comfortable attending anesthesiologists who feel comfortable using these skills, and the lack of equipment and or time to implement these skills. So the limitations of POCUS in general is it takes time to master the technique. The image acquisition is dependent upon the equipment and the operator, and interpretation is operator dependent. If I scan a patient, I might get a different result than one of my colleagues. The limitations to POCUS in trauma care is that no studies have actually been done to show improved outcome from using this modality. Any trauma care typically is time sensitive, and so you have to weigh the risks and benefits of doing these exams versus sending them for more sophisticated imaging or taking them immediately to the operating room, depending on the patient's status. And then also traumatic injuries may preclude these exams from being done. So in summary, lung ultrasound may be quickly learned and expeditiously diagnose pneumothoraces and thoracic pathologies in trauma patients. Airway ultrasounds may be used to perform basic airway assessment, confirm endotracheal intubation and positioning, and identify the cricothyroid membrane. There is potential use for optic nerve sheath diameter ultrasonography in traumatic brain injuries, and the FAST exam may be utilized to identify significant intraperitoneal fluid in the perioperative patient. So this is my team, and I would like to recognize them that I work with at GW, Dr. Ryan Keneally, myself, Dr. Anita Vincent, Dr. Erica Chemtab, and Eric Shekhnirnov, who is a research assistant of ours. I'd just like to take a minute to say it's been a great pleasure giving this talk, and I feel proud to have participated, and I thank you for the invitation. It's a great honor of mine, and I just thank you for your time and your attention. And this is my email address. Again, if anybody has any questions, feel free to reach out. I'm always accessible through email, and I would love to hear from you guys if you have more questions or want copies of the articles that I've written or studied. So with that, I'll open it up to any questions.
Thank you, Dr. Eric, for your excellent talk on POCUS. Now the talk is open for the discussion. Any questions from audience? If there are no questions, then
Eric, it was a very nice presentation from you. Very nice presentation
Thank you.
from you. And everything went very smoothly. And you were live on the
Great.
screen. The credit goes to our internet provider. Credit goes to our internet provider who made everything in time. And it was
Yeah.
really very good that you touched so many good aspects in your POCUS. One is the most favorite of mine is the optic nerve sheath diameter. Because I studied it 3 years ago in Ahmedabad conference for that. And in our conference, there were papers on the PIH, that is pregnancy-induced hypertension. And some of the papers had the mention of the optic nerve sheath diameters. So I had to go through the literature of that because I was the examiner for that. So I was more aware of this optic nerve sheath and you mentioned it. And it is really very good and very easy to make out whether the patient has got increased intracranial pressure or not. But your other things were very good and your videos were also very good. And thank you very much.
Great.
You are still awake
Yeah.
at 1:30 in the night at your place at Washington. Thank you very
Yeah.
much. Thanks a lot.
Yeah.
Thank you.
Thank
Yeah.
you. Thank you.
You want to say anything? You can say. You want to talk anything?
Me?
Yeah?
No, and just again, I'd like to echo. It's been a great honor, and I've really enjoyed meeting with you and the opportunity to present and kind of make this international connection. And you know, yeah, it's late here, but I honored the opportunity, and I thank you again.
Thank you. Thank you very much. Thank you very much for joining with us. Thanks a lot. Thank you.
Thank you, Eric sir, for your excellent presentation. I request Dr. Ashok Deshpande sir and Dr. Misar sir to felicitate Eric sir on. I request Dr. Bharat Hirshi sir to felicitate Dr. Ashok Deshpande sir. I request Dr. B.N. Patil sir to felicitate Dr. Misar sir. I request Heshi sir to felicitate Dr. Misar sir also.